started. Thank you all for joining today's Cancer Education Lunch and Learn series. Today we will be talking about skin cancer prevention with Dr. Whitney Hovenic.
Hi, everyone. Okay. Lily,
Kristen, can you move to the next slide real quick, the housekeeping slide? Thank you so much. So the way today's webinar will roll, just for housekeeping items, if you have a question, please drop your question in the Q&A box or chat. We will continuously monitor the Q&A and chat throughout the webinar, and we will address all questions by the end of the session. This webinar is being currently recorded and will be posted to our YouTube channel. And if you experience any connectivity issues, please log back in and we'll continue where we left off. So our speaker today, as I said, is Dr. Whitney Hovenic. Dr. Hovenic is a double board certified dermatologist and Mohs micrographic dermatologic surgeon with Skin Cancer and Dermatology Institute. She practiced general dermatology at the University of Missouri before completing a fellowship in Mohs micrographic surgery and receiving extensive training in lasers and cosmetic dermatology at the University of California, Irvine. She is a community champion for skin cancer prevention and early detection and has been the singular force behind the Biggest Little Skin Cancer Screening, which will be hosted in Reno on May 7th at the Aces Ballpark. I really hope you all are helping to spread the word on that wonderful community opportunity and will join us there. I will now turn this webinar over to Dr. Hovenic. Thanks so much for being here.
Hi, everyone. Thank you for having me. I appreciate it. I'd love for this to be somewhat interactive. It's somewhat hard to describe how to do a skin check without using an example patient. So I'm going to be talking about what I'm looking for when I do a skin check. But, you know, one thing, when I do a skin check, it can be pretty quick. And so I'm always looking for the ugly duckling, the thing that doesn't look like the other. So it's really important too, when you're starting out and you're looking at skin, you need to really look at what's normal skin and then train your eye for what's abnormal. And I think that's really hard in this setting because I can't show you too many things. I do have some images for you, but I'm going to describe my process and what I'm looking for. And then what I would really encourage any of you to do, if you're interested, is please come to the skin cancer screening on May 7th, and we will partner you with a dermatologist, and you can be there during the skin checks, because your best experience for learning about skin is to look at skin. And hopefully we're going to have lots of skin to look at, so please help spread the word. But if you'd like to show up for that event, the dermatologists are a great resource for you. And you can be in the room during the skin cancer check and see what it is we're looking for, what's normal and what's abnormal. Okay, perfect. Thanks, Lily, for sharing that. As a dermatologist, when you are doing a skin check, it's important to be very systematic about how you look at the skin. Just like if you read a chest X-ray, which I haven't done in years, so don't ask me any questions about chest X-rays. There are certain things you have to look for. You know, if you're doing something over and over again, which you might be doing if you're in a dermatology clinic, and you're looking at skin over and over again, it's really easy to forget to look places because you're talking to the patient, you're having a conversation, you're talking about their kids, you're talking about the baseball game last night, and you might forget to look someplace important. So I have a system when I do a skin check. It really makes absolutely no sense at all, but this is how I've always done it. First of all, when I come in, I obviously ask the patient if they have any concerns, and things that I will specifically ask them is, do you have any moles that are changing in color or size? And I don't know how many of you are familiar with the A, B, C, D, E's of melanoma, but just briefly, we can go over those. So the A is for asymmetry. So one side not looking like another. It's very rare for a mole to look perfectly round and even and that mole be melanoma. Not saying that it can't happen. I'm going to show you some pictures in a few minutes that will make you think that everything could be melanoma. But a lot of times what you're going to see is an asymmetric border. And I have a slide on this that we'll go into in a minute. So asymmetry is the A. B is for border. So if the border has an irregular shape to it, it's scalloped. There's a little offshoot of pigment going off to one side. It looks, there's a little pointy thing hanging off the side, or a little bit of where the borders come somewhat blurry. That's something to pay attention to. C is for color. So color that's not even, color that's changing, that can be part of it. If something is brown and it's becoming white or losing pigment, there's something called a halo nevus, which is where a mole starts developing a white ring around it. Not all of these are melanoma, but this can be a sign that the body is actually mounting an immune response to a mole, which makes the surrounding pigment go away. And that can be a sign that a mole is undergoing some changes, or that the body is sensing something within that mole that it doesn't like. So loss of pigment around a mole is something to remember. D is for diameter, lesions bigger than a pencil eraser. I certainly have diagnosed melanomas that are much smaller than a pencil eraser, so it's not a perfect fit. But for example, I saw a lady the other day and she was very, very freckly, but she had 2 really large freckles on her cheek. And she wanted to come in for a laser treatment. And I said, I can't do a laser treatment on you until I biopsied both of these freckles, because they break the rules. They're bigger than a pencil eraser. They had irregular borders. Fortunately, they were just sunspots. But it's very important that you don't do anything that could potentially destruct a melanoma before you know what you're dealing with. In my world, that means I'm not going to do any kind of laser resurfacing, or certainly a cosmetic procedure on somebody if they have something that looks suspicious for melanoma. And then back to the ABCDs, the last is the E, and this is evolving, which is, I think, in my mind, the most important of the ABCD is the E. So something that's changing. So, and that change may not be perceptible visually, but it might be that it's itchy. You have a mole on your back that it's constantly itchy. That's actually how my mother-in-law figured out that she had a melanoma on her back. She had a pretty bad melanoma, and she's super fortunate to be alive. This was diagnosed 13 years ago. So the only sign that she had that this mole was anything abnormal was that it was incredibly itchy. So she brought that to her dermatologist's attention, and luckily they biopsied it because it actually didn't look that bad. And she had a pretty deep melanoma. She's luckily doing fine. So on that, does anybody have any questions on the ABCDEs? Do you want to put them in the chat?
Whitney, you keep using the term mole. Are there other skin features, like more freckles, or must it be a raised mole that you're specifically referring to?
Right, I know. The word mole is funny because we use it in situations like this, but in dermatology, we actually never use that word. We call it the fancy name, which is a nevus, if it's solitary, or nevi if you have multiple. And typically they can be raised. You can actually have flat nevuses and nevi. So not all moles are raised. It's very hard actually to tell the difference between a freckle and an actual mole, especially because once you get into some bigger freckles, and the difference is actually the cell. A freckle is not a nevoid cell. It's basically pigmentation at the base of the epidermis, but sometimes you just can't tell the difference. So a freckle or a sunspot, the technical term for that is a lentigo. And the fancy word for that, for multiple, is lentigenes. In dermatology, we like to use big words to look smarter, but it's funny. You can use either, but lentigenes are freckles, lentigo is a solitary, nevus, and nevi. What other words do we use? And a sunspot is typically more of a freckle type situation where it's something that's acquired. You didn't have it your whole life. And also on that note, with moles, it's very normal to make new moles into your 40s. So people get very nervous about new moles. And of course, not all moles are moles. I'm going to show you a picture of a mimicker that really often gets mistaken for a mole or a melanoma. And it's not, it's completely benign, and you can make these things called seborrheic keratoses well into your 80s and 90s. So where was I going with this? Lots of terms. So those are the fancy words we use. And then of course, I'm going to cover some other different types of skin cancer in a moment. But I think at this point, actually, I'd like to just take a pause and show you pictures, because pictures do a lot. And then I'm going to go back through on how I do a skin check. Does that work, Lily?
That's fantastic. Pictures would be appreciated. I think if
Okay.
I took away from all your fancy vocabulary, however, the short of it would be, it doesn't matter if it's raised or flat, you still are looking at that A, B, C, D, E criteria.
You are.
Wonderful.
Absolutely.
Let's look at
Okay.
some pictures. Thank you.
Let me get back into Zoom and do a quick share screen. Okay. Can you guys see my slides? Looks like it. Okay.
Yes, they are up and running. Thank you.
All right. So these are just some images I want to go through, and then we'll talk about going back to how to do a skin check. So we haven't discussed basal cell carcinoma yet, but basal cell carcinoma is the most common form of skin cancer. Anywhere between 3 to 5 million of these are diagnosed every year. And in the upper left-hand corner is a nodular basal cell. I think if you're learning about basal cell, this is the picture you're going to see, and it gets described as a pearly pink papule. You can see a shine to the skin, and it can be a bump. But there are many, many varieties of basal cell skin cancer. And one of the more common is a superficial basal cell that looks like a red scaly patch. And we also can have pigmented basal cells that can be very easily mistaken for melanoma. So not everything that's new with pigment is melanoma. And if you get a diagnosis of a pigmented basal cell, it is a much less serious diagnosis than a melanoma. Basal cell skin cancers that get missed quite frequently are this morphic basal cell carcinoma down in the bottom left-hand corner. And you can see it just looks like a white patch. And these basal cells can be mistaken very commonly for scars. They can develop in scars. But what makes these things so bad is that they typically spread far beyond where you can see them in the skin. So a new white patch, or especially one that has a little bit of thickening to it, and especially if you ask somebody, do you have a history of, did you have surgery here before, or do you have a scar from something else, and they look at you with a blank stare, that can be a good clue that you may have a morphiform basal cell. These are also called infiltrative basal cells. And then we have a variety called basosquamous cell carcinoma, which is a combination of features of basal cell and squamous cell carcinoma. And these can look like anything, but most of the times they have a little bit more of this scale rough texture to them. And the way to differentiate between these is to do a biopsy. Clinically, these are things you're going to see on the skin that it's going to say, okay, you should go see a dermatologist and have a biopsy. Or if you're comfortable doing biopsies, these are lesions you're going to want to take a sample of and send to the pathologist. Squamous cell carcinoma can look like, actually very oftentimes can look very similar to a basal cell, but there can be situations where it has this thick scale to it. All of these lesions can bleed easily. So that's a very common symptom that people have, is that they'll take their razor to the area, or they'll be combing their hair and they have this spot that bleeds easily. And that just means the cells are abnormal, and there could be something brewing. With squamous cell carcinoma, we do see these typically more in older patients who've had a lot of sun exposure. But I do have cases. I saw a 30-year-old the other day with a very aggressive squamous cell carcinoma on her cheek. As a doctor, if I do diagnose an early squamous cell carcinoma in a young person, I do think about other factors, including immunosuppression. And does this person potentially have something going on with their immune system that's allowing this cancer to grow? A lot of skin cancers are very dependent on the immune system to keep them at bay. So especially in a young person, if you see a squamous cell carcinoma, you may want to think about, do they have something else happening? And luckily this girl didn't. She just had a very aggressive squamous cell carcinoma. But I actually have diagnosed HIV in a patient who had metastatic squamous cell carcinoma, because I couldn't figure out why a 50-year-old would have metastatic squamous cell. And it turned out he had basically no CD4 cells. So he was in full-blown AIDS, and his metastatic squamous cell was his presenting symptom. This is what we talked about with the ABCDEs: asymmetry, border, color, diameter. There's no slide for evolution because it's hard to show something changing. But that's why you always want to ask people about itching, bleeding, and just new can be a clue. Sorry about the color on the slide. This is something you're going to see all over the place on the skin. These are called seborrheic keratoses, and they appear typically, starting in the 4th decade of life. So you don't see a lot of these in kids, or probably never. But these are more have this stuck on appearance where you could, you almost look like you could scratch it off with your finger, and they have a rough texture to them. These people come in all the time, very, very concerned about their new brown spot. And we say, that's okay, but by the way, you've got this other thing. So that happens a lot. Oftentimes, these are what bring people into the dermatologist, and then we find the real problem. These are not skin cancer. I used to tell people that you can't develop skin cancer in them, but I actually do see squamous cell carcinoma occasionally developing in these things, seborrheic keratoses. The unfancy word for them is, we call them barnacles or AIDS. I don't know. They're horrible. People hate them. They itch. They're annoying. They grow a lot of times in areas of friction, and we can mistake them for melanoma. I mean, if you look at the one in the bottom row, fourth in, I would have a hard time saying that that wasn't a melanoma without a biopsy. So even though clinically, oftentimes we can say this is normal, you don't need to worry about it. There are, if you're not sure, it's always better to do a biopsy. Same top row, second one in from the left. That would be also something where I would look at it, and there is a little clue to it. I could see a little bit of a pattern called a horn cyst at the bottom, but I would still have a hard time calling that benign. It really does break a lot of rules in terms of border and asymmetry. So don't be afraid to send somebody in for something that, could possibly be benign. It's always better to be safe than sorry. And these lesions are going to scare you because these look like, to me, they look like eczema, or they look like basal cell carcinoma. And all of these are melanoma. So sorry, background situation. There is a variant of melanoma called amelanotic melanoma that has no pigment to it. And these are often diagnosed very, very late, because you may say, oh, wow, look at that itchy, scaly spot on your leg. That is eczema. And you prescribe them a steroid, or you recommend a steroid cream, and they get treated for months and they don't go away. So these are hard. These really can surprise dermatologists. Every time I get a diagnosis of an amelanotic melanoma, I'm shocked. Usually I'm biopsying thinking it's a basal cell or a squamous cell carcinoma, typically a basal cell. But that is why it is really, really important to never treat anything without a biopsy-proven diagnosis. So, you may want to consider freezing something like this, or, and you really need to sample it first to make sure you know what you're doing with. But this would be easily mistaken for eczema. So the rule is, if let's say you think something is a rash, and you've prescribed a steroid, or they're using a steroid and it's not going away, they really need a biopsy to rule out any type of skin cancer. I know that there's school nurses on this call, so I wanted to bring up these lesions because these are things you'll see commonly in kids. There's the top two images are of something called Spitz nevi, and these are benign growths on kids that can pop up somewhat suddenly. Typically, they are red or red-brown, dome-shaped papules, and we used to remove all of these on kids because there was a potential risk of transformation to melanoma. But now, most of the time, if we we will biopsy these, especially if they're new, and a lot of times they're freaking out parents, and they're nervous, and we'll do a biopsy, but that's usually sufficient. It'll come back as a Spitz nevis. In the past, we would excise them, but now usually we just monitor it because the risk of transformation to melanoma is actually very low. But they look very similar to the bottom two images, which are something else. Does anybody want to take a guess at what the bottom two images are? You can put your answer in the chat if you have any idea. Okay, I'll just tell you. These are pyogenic granulomas. These can come from trauma, but you can see that the top two images look very similar. The top three images and then the one on the bottom left, they look very similar. They're just this, kind of very round, well-circumscribed red papule. But pyogenic granulomas are just a collection of blood vessels, and they can occur after trauma. They can occur on kids who are taking Accutane. So if you have a teenager near a school nurse and they come in with this new growth on their finger or on their hand, ask them if they're on Accutane, because that is a common cause of pyogenic granulomas in teenagers. And then most commonly they come from trauma, like a mosquito bite develops, and after the mosquito bite heals it from scratching it, they'll get a pyogenic granuloma. They do need to be treated. They bleed very, very easily. Spitz nevi will not typically bleed, but pyogenic granulomas, even the slightest amount of trauma, they can really start bleeding. And you're going to have to send them to the dermatologist to have it shaved off and cauterized because they won't go away on their own. So keep an eye out for those, all of these things, and consider a referral to dermatology. Okay, so that's all I have on the images. Does anybody have any questions before we go back to how to do a skin check? Okay. All right, great. So when we started talking, I talked about my system for doing a skin check and how it makes absolutely no sense. You just have to figure out your system. The reason mine makes no sense is I don't look at body parts in order, but I always look at them in the same order. So as I'm talking to the patient, obviously I'm looking at them already. So I'm really doing an assessment of everything I can see. So I'm looking at their face as we're talking, not necessarily up close. I'm looking at their ears, their neck, their hands, anything that's easily exposed. I'm already glancing at it the whole time I'm talking to them and getting information from the patient. And so then when I actually move on to my real skin exam, for whatever reason, I always look at their back first. I have them stand up because typically they're sitting down when I come into the room and they're in a gown. So when we do skin checks, we have people undressed down to their underwear. I typically let them leave their underwear on unless they have a skin cancer or history of skin cancer in a location in the genital area, which can happen. Or if they have concerns in that area, but typically they're in their underwear. At our skin cancer screening, they're really going to be in loose clothing. We're going to be lifting shirts. We're not changing them into gowns. We'll be looking at anything that's exposed. But I'll have the patient in my office. They'll be wearing a gown. I'll have them come in. I have them stand up, and I look at their back there, and then I remove their underwear, look at their buttocks, and then I do the back of their legs. Then I turn them around and I do the front side. I do their chest, their neck, and their abdomen, and typically their thighs. And then I sit them down and I raise the table up so that I can look at their shins and the bottom of their feet. And at that point, I've covered, 70% of the body. If I find something, obviously we're going to stop. We're going to talk about it. I may mark on their skin a lesion of suspicion to set up for biopsy. We find other things along the way that aren't cancer too. Oftentimes it's Nevada. Everybody's skin is super dry. So we'll talk about lotion. We talk about sunscreen, sun protection. I ask them if they wear sun protective clothing. Do they wear sunscreen? Do they reapply their sunscreen? I also ask them, of course, about smoking history because that's an independent risk factor for skin cancer. And then I've already at this point asked them about their family history of melanoma and other skin cancers. So if they do have a strong family history of melanoma and they have a lot of moles, I'm looking very, very closely at all of their moles. We use a tool in dermatology called a dermatoscope. Oh, I don't know where mine went, but it's a little magnifying light. You'll see everybody at the skin cancer screening carrying them that refracts light. It allows us to look at pigment patterns, and it's very helpful for determining if a lesion is normal versus abnormal. So after I've done that part of their exam, I move on to their hands, the back of their hands, the front of their hands, in between their fingers, their arms, and then I work my way up to their scalp. Scalps are incredibly hard to look at in people with hair. They're great. I love bald men. Their scalp exams are so easy. Women with thick heads of hair, it's incredibly difficult to do a very thorough exam on somebody's scalp. You're picking through their head like a gorilla, you're trying to see everything, and it's very hard to see their whole scalp. If they seem to be somebody who gets their hair colored, I always ask them to have their hair stylist really look at their scalp because when somebody is getting their hair foiled, they're seeing a lot of scalp exposure. And we do get people who are brought into clinic with a recommendation from their hairstylist to have something looked at because they saw something suspicious on their scalp. The last thing that I look at in detail is typically their face. I don't know why, but that's, I've already looked at it throughout most of their exam anyway, but then I'll get up close. I do like to look at their conjunctiva. We see basal cell carcinoma quite frequently on the rim of the eyelid. And a very good clue that you have a basal cell carcinoma developing on the rim of the eyelid is loss of hair of eyelashes. So if they have a gap in their eyelashes, the basal cell carcinoma is basically taking out those hair follicles. And excuse me for 1 second. Can you guys? Oh, sorry, there's a lot of, can you hear the talking in the background?
It's
Okay.
we can hear it, but it's not at all over you. We can hear you
Okay.
just fine. Thank you.
Okay. So eyelid skin cancers are pretty common, especially in fair skinned people, and loss of eyelashes is a big clue. Also, if somebody tells you that they've had a sty for 6 months, it's very unlikely that it's a sty, and they need to be sent to the dermatologist or the ophthalmologist to have that evaluated. And we remove skin cancers on the eyelid here in clinic. We do Mohs surgery, which is a tissue sparing removal of skin cancers, where we're testing and evaluating the margins as we go. But I do involve an oculoplastic surgeon in these cases. Typically, I remove the skin cancer, and then the next day they see an oculoplastic surgeon who does the repair, because this is a very sensitive area. You can also get squamous cell carcinoma on the eyelid as well as melanoma. So we're looking out for pigmented lesions, scaly lesions, anything that shouldn't be there. The other place you need to look is on their lip, especially the bottom border of the lip. This is called the vermilion border. Skin cancer on the lower lip is most commonly squamous cell carcinoma, and they can be quite aggressive. So high risk places for skin cancer, squamous cell carcinoma in particular, are the lip, the ear, the nose, and the temple. So those are areas where things can be more aggressive. I'm sorry, I said nose, I shouldn't have. It's lip, ear, temple. And those have a higher risk of having nerve involvement and the possibility for metastasis. So skin cancers on those areas need a quick referral to a Mohs surgeon. And finally, other places to look, also inside the mouth. There's things that can happen in the mouth that are not necessarily cancer. And inside the ears, really, truly, you want to do a good exam of this area called the conchal bowl. Because the inside of the ear right here going down towards the ear canal, it is surprising how many skin cancers we diagnose and treat in the ear. And that often is mistaken for eczema. People will have an itchy lesion in their ear. It will bleed easily. They're told it's a rash. They're given cortisone cream. But if it doesn't go away, it should be biopsied. So that's how I do my skin exam. I'm utilizing this tool called a dermatoscope, which I apologize, I don't have mine right now. It's missing. But it's a really helpful tool for me. But most commonly, we're using our eyes. So it does sometimes surprise patients how quickly we can do a skin exam. I think a lot of dermatologists will get feedback like, she did my skin check in 5 minutes, but it's because we're looking for the abnormal. And a lot of times people have nothing. Their back might be clear, their legs. I mean, you can really do a skin check when there's nothing on the skin in like 2 minutes. But then we have people who have very complicated skin checks, and it takes a long time. I have a patient who's had, I think, either 11 or 13 melanomas at this point, and she's covered in moles. So I have to spend a lot of time doing her skin check because I'm really truly looking for the ugly duckling mole. And I don't, oftentimes when I've diagnosed these melanomas on her, I'm not even sure what it was that made me biopsy that specific lesion on her when she has hundreds of moles. And so sometimes it's intuition. I know her skin well. Sometimes there's, pigment patterns that have, I'll look for and I'll say that one looks abnormal, but that's what you're looking for, is the abnormal amongst the normal. And it can be very intimidating when you first start looking at skin. It's not something that most people learn anything about in nursing school, or very little typically. We learned very little about the skin in medical school. I think I got a week of dermatology, and then before I went and became a dermatology resident. So skin, even though it's our largest organ and it's out there to see, we don't necessarily know a lot about it. And that's why you need to be comfortable sending to somebody who is comfortable if you ever have questions about a lesion. So does anybody have any questions?
Whitney, I just would ask what your recommendation would be for people if they are doing their own self-awareness. How often is there harm in looking too often? How often should you be looking?
So it really depends too on your family history, and also if you have a history of skin cancer. But I would say in general, just once a month, kind of give yourself a look over. If you if you look at your skin every day, you may not notice what's new. So if you're, eyeball yourself in the mirror before getting into the shower once a month. Look at the bottom of your feet. I think that's a forgotten place. I realized I had a mole on my toe the other day, and I'm like, oh, I don't know how long that's been there. So I'm going to watch it. If it changes, I'll do a biopsy on it. But, knowing your own body, and obviously if you have a lot of moles, this is really complicated. You can't keep track of all your moles. My husband is covered in moles, and he's had a melanoma. So, I look at him probably once a month, and then I'm not his dermatologist. So then he goes in every few months and gets his skin checked. So if you have a lot of moles, it's really important to keep an eye on your own moles. But I would say establishing with a dermatologist, especially in your 30s, to start getting skin checks. Transplant recipients, yes. So people who have had transplants, solid organ transplants, kidney, liver, lung, heart, have an incredibly high risk of squamous cell carcinoma. So 100 times the risk of squamous cell carcinoma due to the medications they're on to protect their organ from rejecting. So there are certain medications that patients take that are worse than others. If you have somebody who is taking a medication called Imurin, they have a very, very high risk of skin cancer, of squamous cell carcinoma. Some of the other drugs, Cellcept, Prograf, they all have an increased risk. Every single transplant patient should be seeing a dermatologist. And typically they start developing a lot of skin cancers about 5 to 7 years after their transplant. But if they have a lot of sun damage prior to having a transplant and they've already had skin cancer, they're going to start making more skin cancers by the much sooner into their history after their transplant. Okay, so I have a question on what parts of the body do you see the most skin cancers? And typically those are sun exposed areas, ears, cheeks, nose, and neck, anything that chronically gets sun. But you can get skin cancers in areas where there's no sun exposure. I've had 2 patients with skin cancers in the genital area about a month ago, which you would not think of that as a sunny area. You do need to ask, and I didn't talk about this, you need to ask about tanning bed history. So tanning beds do significantly increase the risk of skin cancer, particularly basal cell carcinoma and melanoma, and really discourage anything, especially if you guys are working with teenage girls. Tell them to never, ever, ever go into a tanning bed. It is the worst thing for them. I have a patient coming into this afternoon who used tanning bed. She's already had 3 melanomas. We see very early basal cell carcinoma in people who've used tanning beds as teenagers or as young adults. And it doesn't even have to be all that frequent, but it's an incredibly high. Lily, what did we say? 5 times the strength when you're in a tanning bed, you're getting 5 times the UV exposure than you would if you're just sitting outside in the sun. Any other questions?
Not seeing additional questions. I will say the images were absolutely startling. Oh, we do have a question about sunscreen, and if you want to expand on the sunscreen to other sun safety strategies,
Oh, sure.
prevention,
Absolutely.
or what people should be doing if they've had skin cancer.
Yeah, well, sunscreen, so prevention is key. So prevention comes in all shapes and forms. Obviously, we live in a beautiful sunny place, but you have to be careful and protect your skin. This really is important for kids on playgrounds. I wish that we had a better system for making kids wear hats here in Nevada, because I watch my own kids out on the playground and I just am mortified by how much sun they're getting. And I would love to implement a hat rule like they have in Australia to help prevent early melanoma and sun exposure, but we don't have that here. So it's very important that everyone is wearing sunscreen every day, particularly when you're going to be outdoors. You need to reapply it though. You can't just apply it in the morning, and you should never use a spray as your first application. If you use a spray, watch how much of it just goes off into the wind. And also you need to remember the SPF factor that's on there is tested with a very thick layer. So usually when they are determining SPF, they are using a shot glass amount of sunscreen applied to the body. Do you all use a shot glass amount of sunscreen to your body when you apply? Because I know I don't. So that SPF determination is really not what you're going to get as the normal average sunscreen user. So pretty much divide that number in half. If you're using a 50, you're probably only using enough sunscreen to get an SPF of 25. And in Nevada, with our sunny climate and all the reflection off of water and rock, we're getting a whole lot of UV exposure. So you need to remember to apply your sunscreen at least 20 minutes before you go out. And then you really need to reapply especially if you're sweating or you're in the water, about every 90 minutes. And I think that's the hardest thing. I went backcountry skiing on Sunday and I just kept my sunscreen in my pocket and like every hour just slathering it on. So you just have to remember to do that because as you're sweating, it's coming off. And mineral-based sunscreens are better. They're forming a barrier on your skin against the UV, which then reflects the light. So those are zinc, titanium dioxide. They don't have to be white. I use ones all the time that are brown because I like how they like coverage on my skin. There's a lot of formulations of zinc and titanium that are not that thick toothpaste like zinc of, those of us who grew up in the 80s with the zinc sticks on our nose. There's great formulations. You just need to try them and figure out what works best for you. And then I'm a huge fan of sun protective clothing. So the more you can cover your skin with UPF fabric, the easier it is to be outside because you don't have to worry so much about reapplying. One place that's crucial though is the back of the neck. As a woman who wears a ponytail and I'll wear a hat and I'll wear a hoodie with sun, there's still a pretty good gap of even with the wide brimmed hat where the back of your neck gets exposed. So please remember that. And then inside your ears and on tops of your ears, those are sort of the forgotten zones for sunscreen. But UPF fabric is wonderful. You can wash it if you wear the same thing for 6 years, it's probably going to degrade some, but look for UPF 50 fabrics. There are many, many, many companies now that put UPF fabric in. And so normally a white t-shirt will give you an SPF factor of 4, but you can buy a white UPF t-shirt with an SPF of 50. And I found for me, covering up and not having direct sun on my skin, I stay cooler. And especially if you can get the fabric wet, let's say you're out for a hike, take your shirt, dip it in a creek, put it back on, you'll be nice and cool. But the sun protective clothing is really great. And don't forget the backs of your calves. I didn't mention that's a very common place for melanoma, especially in women, from wearing shorts and not putting any kind of protection on the back of the legs.
We did have a question going back to tanning beds. How long does it usually take for tanning bed damage to occur or to be discovered?
So I don't have a perfect statistic on that, but it seems that people who have tanning bed exposure in their teens start developing basal cells and melanomas in their 20s and 30s. It's early. So at, a 10-year gap, we don't have a great temporal relationship between like you use a tanning bed, you're going to get a skin cancer here. Some of it depends on your immune system, your genetic makeup, and your family history. So, but it's not normally right away. Just like with actual UV. So basal cell carcinomas, a lot of that comes from sun exposure as a kid. Squamous cell carcinoma, the more sun you get over the years, the more squamous cell carcinomas you get. Melanoma can also just be, 5 bad sunburns as a kid. Your melanoma risk is doubled. So, but usually there is a gap. And a lot of that is because the immune system fights off a lot of that damage for a long time.
Do you have any recommendations for repairing sunspots? And I'll just add on to that. Does that remove some of the risk?
So that's very good question, Lily. So we actually use lasers a lot in dermatology to help with sun damage, and lasers are not just for cosmetics. We can actually reverse a lot of aging and a lot of actual sun damage and reduce your skin cancer burden. So although lasers make your skin look pretty, they're actually helping as well. We have other treatments too. We have a treatment in our office called photodynamic therapy that can help selectively target precancerous cells. There's creams you can prescribe to people who have a lot of the precursor lesion to squamous cell carcinoma is called an actinic keratosis. And those are the things, if you go to the dermatologist and they get out the mean can and they start freezing these things, that's what we're treating. But we can actually treat like the whole face with something called photodynamic therapy and cut back on the skin cancer, your skin cancer risk because we're treating the precursor lesion. There's actually a vitamin called nicotinamide, which you can take twice a day, 500 milligrams, that's been shown to reduce skin cancers by about 25% if you take it for 2 to 3 years. Not niacin, by the way, if anybody of you is writing this down, nicotinamide And I'll put it in the chat because people buy the wrong stuff. And it's just a B vitamin. It's but I think, other things we've talked about, staying, keeping your skin protected. I didn't mention staying out of the sun at peak sun hours, which pretty much the fun time to be outside. So, you know, like those of us who are skiers and runners, and I try to run early in the morning in the summer. I was backcountry skiing all day Sunday. I was out in the sun, but you just have to be smart. You have to reapply, wear your sun protective clothing. Don't hide in a bubble. Even if you have a history of melanoma, you need to go outside. It's good for you. It's good to get out, keeps your soul happy. But just protect your skin.
And seeing no more questions, I think that's the perfect place to end on. You have to go outside. So
Yeah.
think about what time you're outside and protect your skin.
Right. And if you're going to go out right now and enjoy the last 15 minutes of your lunch, put on your sunscreen and, find a hat, take a hat to work with you and, get out on your lunch break, take a little walk, get some air, but, keep your largest organ protected, please.
Well, thank you so much, Dr. Hovenic, and for all of you participating. Again, this will be posted on the website. If you have any follow-up questions or want more information on the May 7th event, please reach out to myself. We're really excited about it.
I hope to see all of you there.
Take care, everyone.
Okay. Thank you.